Hello.
Hello, Dr. Naji.
Hello. Good afternoon, my sister.
Dr. Naji, how are you?
I'm fine. Thank you.
How
are you too?
Thank God. How is yonder?
We're fine in Bakaliki.
How is your family?
We're fine. How about yours?
Salt of the nation. Ebonyi State, salt of the nation.
Yes, we have a lot of salt here and sparkling environment.
And everything salty in that nation. That's a fact.
We have a lot of salt, not everything. We don't have everything salty, really.
Salt, but your rice tastes better than any other rice.
Definitely. Our rice is the best in the country for now. And it's going to remain like that for a long time.
Also the yam. So it's a very rich it's my own state.
Not just the yam, but the yam is medicinal.
Exactly. So what have you discovered it does?
Well, I think there's speculation that it does improve fertility.
Yes, it does. That's why
fertility.
Women, once you touch them, they are pregnant.
Exactly.
Oh, God.
Hey, better watch it though, and stick to your own.
No. I mean, we're okay here. We're okay. I have I've already completed my family, and I'm all right.
Okay. Good afternoon, everyone.
Madam, now. Try.
The madam is also eating the yam, so.
Madam is eating yam, but we don't have any problem.
Okay. Evidence based.
Good afternoon, Madam President. Good afternoon, Evu VP, VP2.
Peppy baby. Peppy
baby.
Good afternoon. Good afternoon. It's some minutes past 3, so we.
Peppy. Ụmụazị a nọzi ebe ahụ. Nyefe ife achọ. Peppy.
Yes, ma'am.
Give them what they want now. Show they did then. The pickings.
Okay. We have to start. It's 4 minutes past 3.
Okay.
Can you hear me?
Very well.
Oh, great.
I can hear you. But I want to get it to the full screen.
Okay.
My screen is half.
All right.
And the control.
And we can't see your full face, Dr. Naji.
Okay, you're seeing it now?
Yes, very good. Good afternoon, everyone. On behalf of the Nigerian Association of Dermatologists, I would like to welcome you to this month's webinar. Dr. Perpetua Ibekwe, Secretary of Nigerian Association of Dermatologists. We'll be hearing from our president towards the end of the presentation. Today, we'll be hearing from our able erudite scholar from Kano. They have obliged us to teach us today on Pemphigus and Bullous Pemphigoid. And I believe we're going to learn a lot today. Our moderator for today is Dr. Naji. He's with the Federal Medical Center. Sorry, it's now, it has a new name, sorry.
Alex, the new name is, yeah.
Alex Ekweme Teaching Hospital.
Federal University.
Federal University.
Teaching Hospital.
At Abakaleke.
It's true, pronounce it very well. Happy.
Yes.
I hear.
So he's going to be our moderator today, and we have two presenters, Dr. Awal, who is a dermatology resident at the Aminu Kano University, and also Professor Shehu. I'll be handing over to Dr. Naji to continue proceedings. Dr. Naji, over to you.
Good afternoon. You're welcome to this webinar organized by the Nigerian Association of Dermatologists. This particular one, we are going to be hearing from our colleagues in Kano. We thank everyone, the president of our Ebola Association, the immediate president, Grace Okudo, and the current officials of the association. We are grateful for this opportunity given to us to learn. Good afternoon, all my teachers, colleagues, and everyone who is listening. We're going to start immediately because we're a little behind schedule. The keynote speaker is somebody that we know very well. He's an erudite scholar. He's a man of integrity. He's a lecturer, a clinician par excellence. He's no other person than Professor Yusuf M. Shehu. He is of the Aminu Kano University Teaching Hospital, Kano, in Kano State. We have also his resident, Dr. St. Awal, in the same department. We're going to be discussing immunobullous disorders. We have two case presentations that we're going to be listening to immediately. Prof, I hope you're listening.
We are.
All right, and your resident is ready?
Yes, we are. Thank
you. Can you say one or two things before we kick start?
Good afternoon, everyone, and thank you for having us to host today's presentation. Like the moderator already introduced us, the topic for today is going to be diagnosis and treatment of pemphigus and pemphigoid. It's been narrowed to these two, and therefore it's not just immunobullous disorders, because that would be a very wide topic. So we're going to see to it that we narrow our discussion to these particular two conditions, and emphasis will be on the diagnosis and treatment. Thank you very much. So I'll hand over back to the moderator, Dr. Naji.
All right, thank you very much for that. That we're going to be specifically discussing just two among many of the immunobullous disorders because they're quite wide. We're going to be discussing pemphigus and bullous pemphigoid. And I think we just have to start. Let's invite Dr. St. Awal to do his case presentation. Dr. Awal.
His screen is not shared. You have to allow him to share the slide.
Dr. Naji, please stop sharing your slide.
Oh, is it my slide that is?
Yes, it is yours.
Okay, so how do I, sorry.
Click in the share screen and then stop sharing. Have you seen that?
My
Your desktop.
Go to the green bar.
okay.
There's a green bar there up. Then highlight that. You see where it says share slide, and then you click on that button.
Okay.
I've removed
yeah,
it.
yeah.
So Dr. Awal, please, can you go ahead and share your screen?
Yes.
Okay.
Please go on.
My respected teachers and my colleagues, good afternoon to you all. I'm going to give a case presentation on Pemphigus Vulgaris and Bullous Pemphigoid. And the case one is Pemphigus Vulgaris. I'm presenting Miss H.A., a 56-year-old widow with 3-month history of painful mouth ulcers and 2 weeks history of fluid-filled lesions all over the body. These lesions were described as blisters that are easily breakable, with associated pain and burning sensations all over the skin. No associated history of fever or joint pains, no associated nail or hair involvement, no past history of similar illness, and she's not a non-hypertensive or diabetic. She neither smokes or consumes ethanol. A review of other systems is essentially not remarkable. On examination, this woman was found to be not febrile, not pale, anictetic, acyanosed, with some dehydration and no edema state. Her pulse rate was 100 beats per minute, blood pressure of 130/80 millimeters of mercury, with a respiratory rate of 20 cycles per minute. Cutaneous examination shows very few intact flaccid blisters with mainly widespread erosions involving the trunk, the face, and the extremities. As we can see from the slide, this is one of the few intact blisters that she has, which contains clear fluid. Another view of the same patient with, you can see widespread erosions and background erythema. This is another small intact blister that she has. A closer look at the face shows widespread erosion involving most part of the face and then the trunk. Complete blood count and electrolyte urea and creatinine were actually not remarkable. Punch biopsy was taken, and histology shows the typical suprabasal clefting with the typical tombstone appearance and acantholytic cells. So patient was admitted, and every fluid was given 500 normal saline 500 ml 8 hourly. She was given IV paracetamol infusion 1 gram 8 hourly, and she was commenced on prednisolone 20 milligrams in the morning and 10 milligrams in the evening, with Depson 100 milligrams daily, tetracycline 500 milligrams 8 hourly, and she was given omeprazole 20 milligrams BD with calci D3. Actually, after 5 days of admission, there were no new blisters forming. Patient was actually, because of financial challenge, was discharged 9 days after admission, and she was continued to be followed up in the clinic. Over the time, steroid was gradually tapered. Currently, she's on 10 milligrams of prednisolone daily, and then Dermovate ointment was added topically to be applied daily. 6 weeks after, patient's skin was good and smooth. This is the one of the pictures that she has during her recent visit to the clinic, and there were no blisters, no erosion, just with post-inflammatory hyperpigmentation. Yes. This case 2 is that of Bullous Pemphigoid. I'm presenting Mr. IB, who is a 21-year-old undergraduate presented with 5 weeks history of generalized pruritus, followed by gradual development of tense bullae, mainly all over the body, on the trunk, groin, on the thighs, extremities, including the flagellal aspect. However, there is no mucosal involvement, no nail or hair involvement, no peripheral lymph node enlargement. He has no personal or family history of similar illness. It's not a non-diabetic or hypertensive. It's not on any medication. He has tried several medications, including traditional medications, before presenting with no response. So he was found to be moderately built young man, not febrile, not pale, not jaundice, not dehydrated, and no edema state. He has a pulse rate of 82 beats per minute, blood pressure 120, 70 millimeters of mercury, a respiratory rate of 18 cycles per minute. And this his picture on the first visit with widespread tense bullae all over the body, on the trunk, extremities, and the thighs, everywhere. This is another view of tense blisters that he has. This is histology that shows the subepidermal clefting. It was taken at around the perilegional area. So we can see the subepidermal clefting with plenty eosinophils there. He was given prednisolone 20 milligrams 12 hourly with dapsone 100 milligrams daily, tetracycline 500 milligrams TDS, omeprazole, and calcidiphilin. However, there was no improvement after 4 weeks of commencement of therapy. So azathioprine was actually added 100 milligrams initially. In fact, it has to be raised up to 200 milligrams before he achieved significant response. And prednisolone was tapered gradually, and he is now being followed up in the clinic. And this is his picture several weeks after commencement of therapy. Thank you very much. Thank you, sir.
Hello,
Thank you, Doctor.
Yes.
I think we continue.
Okay.
With Prof before we ask a question.
Okay. A minute before we post in the slide. Good afternoon. I hope my slide is viewed by many. I'm going to be discussing the diagnosis of pemphigus and pemphigoid. But before I go to that, I need to introduce what pemphigus and pemphigoid really refers to. By definition, both pemphigus and pemphigoid are a heterogeneous group of autoimmune blistering disorders where autoantibodies are generated against targeted antigens found on the skin and mucous membranes. Precisely, desmosomes and hemidesmosome components are the main targets. So what happened is that the term pemphigus actually refers to autoimmune intraepidermal blistering of the skin disease, while pemphigoid refers to blister that occurs at the dermal epidermal junction in general. Although not every subepidermal bullous disease bears the term pemphigoid in the nomenclature. You will notice later that it's only applicable to, but not exclusive of, all members of the pemphigus group. So pemphigus is a collective name for intraepidermal autoimmune blistering disorders. Now, there are so many variants of pemphigus, and there are so many. The first is Pemphigus vulgaris, as the name suggests, is the commonest type. Vulgar means common. So Pemphigus vulgaris is the commonest variant, and then there is Pemphigus vegetans, Pemphigus
Sorry, we
facials.
can't see your slide, Joe.
You can see it.
Yes, it's the old slide that is showing.
Okay, let me, please bear with us. Let us log out. Let us log out, please. Yes, how do you log out? Otherwise, your own. Remove your own.
Please try it again.
Yeah, we are
Try
trying
to share again.
Yes. Yes. All right. Can you see mine?
No, still not seeing your slide.
You can't see it.
I can't see. I don't know if other people are seeing.
Try to share it again. Try to click on the share slide, share screen.
Yeah.
Okay. Let me share screen. What of now?
Yes, I can see. Yeah, the slides are there. Yeah.
So can I start all over?
Yes.
Yeah, you can start.
All right. Just as I mentioned earlier, the discussion would be on Pemphigus and Pemphigoid. And what I said was the two conditions, Pemphigus and Pemphigoid, are heterogeneous group of autoimmune blistering diseases where the autoantibodies are generated against targeted antigens found on the skin and mucous membrane. And precisely, they're the components of desmosome and hemidesmosomes that are targeted. And I said Pemphigus actually refers to intraepidermal blistering skin disease, while Pemphigoid refers to the blistering disease that occur at the dermoepidermal junction. But then not all epidermal blistering disease bear the term Pemphigoid either as a suffix or prefix, as it is the case of Pemphigus. Pemphigus therefore refers to collectively intraepidermal autoimmune blistering disorders, and there are so many variants. The Pemphigus vulgaris, vegetans, foliaceous, a variant of foliaceous also called Phogos salvation, and then Pemphigus erythematosus, Pemphigus neonatorum, paraneoplastic Pemphigus, and IgA Pemphigus. These are the variants of Pemphigus, which we are not going to discuss all, but we take the commonest variant, which is Pemphigus vulgaris, as the name suggests. It is the most frequent and the most severe form of Pemphigus. Without proper treatment, Pemphigus vulgaris can be fatal with mortality around 10%. And septicemia being the most common cause of death. The condition usually starts around the age of 40 to 60 years, and it has a worldwide distribution affecting both male and female equally. The etiology of Pemphigus vulgaris is usually as a result of autoantibodies that are produced against desmosomal glycoproteins, precisely desmoglein 1 and desmoglein 3, which are transmembrane glycoproteins. Pemphigus vulgaris is strongly associated with other conditions, especially myasthenia gravis, mucositis, insomnia, hidradenitis, and many hematological neoplasias. But most times these conditions are not really seen. By way of presentation, the condition usually begins with blisters and erosions in oral mucosa, and later blisters are seen on the skin, which may spread to be disseminated. Mucosal lesions tends to be the first to manifest in up to 50 to 70% of patients, and in 90% of patients during the course of their illness. On the skin, what it normally becomes obvious are these very flaccid blisters, which easily ruptures to leave these painful erosions that often bleed and get crusted. They may also involve, the crusting may be seen in the nose, the mouth, the larynx, the pharynx, and vagina. Most of the blisters, if found intact on the skin, tends to have positive Asby Hansen's sign, while if pre-lesional skin is really pressed, you may have positive Nikolsky sign. And this is a picture of a typical patient with this condition. You can see the erosions and few intact blisters. Again, this is the same patient after few weeks, not a week really, few weeks of treatment while on admission. Most of the blisters or the erosions have dried out, and there are no few new eruptions coming up. This is another patient with few intact blisters and crusted erosions. Again, another patient. On the left is when the patient presented, and on the right, a month after treatment was initiated. Similarly, this is another patient with crusted erosions with no or very few intact blisters. Same patient, there's another patient with florid crusted erosions. Again, sometimes Pemphigus vulgaris may present in a localized form. Like I mentioned earlier, there are so many variants depending on what is the target antigen. And desmoglein 1, 2, 3, 4, but the common one affected are desmoglein 1 and 3. Desmoglein 1 is found solely on the skin, and therefore, while desmoglein 3 on the mucosa, so one can present with essentially mucosal affectation as only presentation, or patient may have mucocutaneous presentation. Here we present a localized form of scalp Pemphigus vulgaris, where you see erosions, crusting, and scaly plaques that eventually led to alopecia. Luckily enough, the patient regained the growth of her hair after treatment, as you can see in the picture on the right. Now, how is Pemphigus really diagnosed? Diagnosis can be hazarded clinically based on the presentation, but then there are certain specific investigations that one has to do in order to confirm. You may be restricted in many areas where you don't have most of what is necessary to make definitive diagnosis. So we have to do with what we have, the clinical acumen and the help of dermatopathologists. So histologically, one is to send for H&E, normal H&E, routine H&E, and then punch biopsy can also be sent in good centers where immunofluorescence is there for direct immunofluorescence, or one can take serum and send for indirect immunofluorescence to check for the desmoglein 1 and 2, or even ELISA to check for the antibodies to desmoglein 1 and desmoglein 3. So that can be done in order to make diagnosis. Usually, H&E will show the typical suprabasal cleft. Occasionally, you may see the classic finding as in this slide, where you see the tombstone appearance of the basal keratinocyte and the cleft, where you have the, what do you call it, and a few lymphocytic, infiltrate in the, what do you call it, upper papillary dermis, and then within the cleft. So this is what you see. Occasionally perivascular, lymphocytic, and eosinophilic, infiltrates with obvious acantholytic cells in the fluid cavity. That's a typical finding. This is not my slide. It's borrowed courtesy Professor Martin Black, St. John's Institute of Dermatology, where you see the typical direct immunofluorescence, where you see intercellular IgE deposit, more of IgG than C3, giving this basket woven appearance of fluorescence. That confirms usually the diagnosis. Now, typically to establish a diagnosis, you have to fulfill these three criteria. One, the appropriate clinical features, the histological changes showing the acantholysis of the affected epithelium, and then the demonstration of the IgE autoantibodies as shown in the direct immunofluorescence. But one can do, like I said, you can do ELISA to take antibodies, or you can do indirect immunofluorescence, of the serum. So you can do that to make diagnosis. Treatment is often quite prolonged. It can last many years. It can be lifelong. So treatment is really something that we need to pay attention to. And the aim of the treatment is to achieve and maintain disease remission. Now, how do we do that? The backbone agent used for the treatment of Pemphigus vulgaris is prednisolone oral steroid in the range of 40 to 60 milligrams per day. But in severe cases, one may raise the dose up to 60 to 100. So the usual dose should be 1 to 3 milligrams per kilogram body weight. Again, you can give post-dosing in order to reduce the side effects, especially that can accompany prolonged use of high-dose steroid. So one can use methylprednisolone from 500 to 1 gram, or equivalent dose of your dexamethasone, which is about 100 milligrams to 300 milligrams on day 1 to 5 consecutive days, and then you repeat monthly, something like that, until you achieve remission. And then you may need to sometimes add on cyclosporine, depending on the severity of the illness. It may be as a first dose, where you give your dexamethasone or methylprednisolone for 3 doses as say 100 milligram dexamethasone, or methylprednisolone 500 to 1 gram as a single dose, at a single dose of cyclophosphamide given monthly. And then you can also maintain on a 50 milligram of cyclophosphamide daily with your prednisolone, which you give as 1 milligram per kilogram body weight as a maintenance. Now you continue this regimen until the patient has achieved remission. And remission can be said if the most of the lesions are no more erupting or they are drying out. So if the patient has reached, say, 2 weeks without having any new eruption, one can simply start tapering the steroid, and then you maintain over a long period of time. Most times you may need, as in the case of our patient who had pemphigoid, which is not the usual thing, but you may have to add azathioprine, a steroid-sparing agent. The thing is, one can use azathioprine as a lone drug, but it's not really advocated because it takes about 4 to 6 weeks to achieve full therapeutic effect, and that restrict its use as a monotherapy. But then it can be used as an add-on in order to achieve remission with other agents like your prednisolone and other agents. Other agents that can be used include rituximab, especially in severe refractory cases. Again, this should be given as an IV slow infusion over 2 to 6 hours. Now, other steroid-sparing agents which can be used aside from azathioprine include your methotrexate or dapsone, or a combination of tetracycline and nicotinamide, or just tetracycline and mycophenolate mofetil, and then plasmapheresis or immunoglobulin. So actually, in very good centers where this cost is not a prohibition or availability is not a factor, the regimen is to administer rituximab with systemic corticosteroid with additional use of immunoglobulin, or to administer rituximab with systemic corticosteroid plus any antimetabolite such as azathioprine or mycophenolate. But where rituximab is not applicable, one can use corticosteroid plus cyclophosphamide with possible addition of short-term plasmapheresis. These will reduce the production of the autoantibodies as well as to clear the circulating autoantibodies when you do plasmapheresis or you give your rituximab to achieve remission. So on top of that, another thing that we should not forget for all patients on systemic corticosteroid, which I'm sure will be on it for a very long time, one should start prophylactic supplemental calcium and vitamin D. And if you remembered what my resident presented, usually our patient will add on calcium D3 as a single dose, daily dose, in order to prevent osteoporosis and other things. And then we also give omeprazole to prevent peptic ulceration. And we also, monitor blood sugar as well as blood pressure on all visits. Now, prognosis is usually better in children than adults, but one thing we need to know is if Pemphigus vulgaris is left untreated, it may be life-threatening, as the loose skin or the dysfunctional skin barrier may lead to loss of body fluid, malnutrition, and secondary infection, which is usually the main cause of death in most of these patients. So the caveat here is pemphigus, you should know, is a very notorious condition, and for its persistence, and then spontaneous remission typically do not occur. And you should know that it's always associated with remission and relapses. Most patients, therefore, will require some form of treatment for life. As I mentioned earlier, treatment usually averages 5 to 10 years on a maintenance treatment. It may be as little as 5 milligram prednisolone, but one has to be aware of that. Now, these are just to show us some variants of pictures of some variants we have seen of pemphigus condition. The first on the screen is Pemphigus foliaceus. You can see hardly do you see any intact blisters, but you see flaky erosions on the skin, and it's usually the whole skin, so it affects from head to toe, but they are wet crusts, these are. And then the other picture here on the screen is to show a patient who was managed as a case of Pemphigus vegetans. On the left, you see when the patient presented, and then 2 weeks later, the picture was taken of the same axillary. Another similar condition, another crusted, Pemphigus vegetans before and after pictures. Now that ends the lecture, the presentation on Pemphigus vulgaris. I'll go straight to Bullous Pemphigoid. Now, a number of autoimmune subepidermal bullous skin disorders are linked to specific autoantibody directed at components of hemidesmosomes, for which Bullous Pemphigoid is one of them. So there are so many variants of, subepidermal blistering diseases. Bullous pemphigoid is just one of them. We have paraneoplastic pemphigoid, cicatricial pemphigoid, epidermolysis bullosa acquisita, chronic bullous disease of childhood, dermatitis herpetiformis, bullous SLE. We also even have porphyria cutanea as one of the conditions that present with subepidermal blistering disease, which can be a differential of Bullous pemphigoid. and they have subtle differences that you differentiate one from the other. So bullous pemphigoid is the most common autoimmune blistering disorder. It's much commoner than pemphigus and is less severe. I mean, it's not really life-threatening as it is with bullous pemphigus. Typically, bullous pemphigoid occurs in patients that age above 60 years, as against what I mentioned in bullous pemphigus, where you have the condition occurring mostly between the ages of 40 to 60. But then it can affect any age group. As you can see, even the bullous pemphigoid, which normally is seen in patients above the age of 65, 80, you may have anybody in any age group presenting with bullous pemphigoid, but most commonly elderly individuals. Now, the main etiology here, the body produces autoantibodies against specific antigens in the hemidesmosomal region, in the dermoepidermal junction. The typical ones affected are bullous pemphigus, or the type 17 collagen, which is a 180 kilodalton glycoprotein. There is a transmembrane hemidesmosomal protein. And the second one is the BP antigen 1, which is a 230 kilodalton glycoprotein, and is usually a transmembrane, or so to say, cytoplasmic plaque protein. So actually, it is found in a hemidesmosomal protein rather than the type 2, which is the type 7 collagen, is found, that traverse through the lumina, lucida through lamina densa in the dermoepidermal junction. So these are the main glycoproteins that are attacked. And how do they present? Usually patients present initially with urticarial lesions, which evolve into large, very tense blisters over many areas of the body, including the thighs, the groin, the abdomen. If you look at the slide, on the screen, you see the pudoranged skin on the side of the abdomen, which is the urticarial lesion. And then you may see surmounted on those lesions, you may see tense intact blister. That's the typical early presentation. Most times the patient just presents with the tense blisters. You might not be lucky to catch them in a stage where they have the urticarial lesions. Again, the lesions are usually preceded by a lot of itch. So there is itching with tenderness of the skin. Luckily enough, patients will not have constitutional symptoms, and lesions might not be very extensive. Mucosal affectation, as against what you see in most patients that have Pemphigus vulgaris, it affects less than 35% of patients. So mucosal affection is not a very prominent feature of bullous pemphigoid, as against what you see in Pemphigus vulgaris. Now here is on the screen a typical lesion on the dorsum of the hand of an elderly man. You can see the tense blisters that are very difficult to break, because the roof is formed by the whole layers of the epidermis. So it is a subepidermal lesion, right? And you can see here some of the lesions the patient tried to break them, but you can see a few of the intact tense blisters. And this is another patient. They tried to burst some of the blisters on the dorsum of the leg, but then she still presented with this very tense blisters in the extremities. Again, this one of the patient, you can see the before and after. On the left, you see the erosions and the tense blisters. And then on the right, after a month's treatment with some medications, she presented with no blisters, but post-inflammatory hyperpigmentation and few scars. We should also remember that some drugs may also present with bullous pemphigoid-like lesions. So notable culprits include furosemide, vermetimide, spironolactone, phenacetin, penicillins, D-penicillins, captopril, fluoxetines, and all other ones on the screen. Now, how do we make diagnosis of Bullous Pemphigoid? Diagnosis is similar to what we did for Pemphigus vulgaris. Biopsy should be taken of the intact bulla or blister for histology with H&E. Again, we can also take pre-lesional skin for direct immunofluorescence and send in Michel medium for transportation to the lab. But that is for those who have this facility. Again, if you have facility for ELISA or direct immunofluorescence, you may also take the serum to check for antibodies in patients with suspected case. Now, treatment-wise, treatment is almost similar to what you see in patients with Bullous Pemphigus. So we give prednisolone, but then the dose tends to be a little bit lower because they respond very fast, except in few cases, as is the case of the patient we had, where we had to increase, we gave almost all the drugs shown on this screen, except for the topical agent, which we give at the tail end. But we've given prednisolone, we give azathioprine, we give tetracycline, we give dapsone. So these are the major agents usually that are given. You can start with prednisolone alone or with any of the steroid-sparing agents available to you, including rituximab where available. But then usually we give prednisolone. In our own center, we give prednisolone with tetracycline, dapsone, and we give lower doses of these particular medications. Histologically, sorry, I think this should have come earlier than the treatment. Histologically, this is what you are likely to see if the blister, the punch biopsy is taken close to the blister. You may see just the cleft, but then the papillary dermis will show a lot of eosinophilic infiltrate. You may see here the small clip as the blisters are forming, and you can see the small clip in the subepidermal area, and the epidermis is getting detached in this slide. Here, this is an intact blister, and you can see the roof formed by the whole layers of the epidermis. And within the blister, you can see large numbers of eosinophils and a few lymphocytes. Right. This is another slide, courtesy Martin Black, Professor Martin Black, retired professor from St. John's Institute, and you can see the linear arrangement of C3 that is showing like a straight line in the dermoepidermal junction. That is the arrangement of the C3 in this slide if you do direct immunofluorescence. I think that's the end of the presentation. Thank you very much for listening, and I'll await your contributions, additions, deletions, and few questions. Thank you. Over to you.
Hello. Thank you very much, Professor Yusuf. It's been a wonderful time to have you. You've really given us a lot of things. I wonder whether I'll be able to really summarize this because the stuff are just too much. But thank you. You started by telling us that immunobullous disorders are a heterogeneous group of addressing diseases where immune system plays a vital role. Of course, you narrowed to just pemphigus and pemphigoid because if we are to discuss immunobullous disorders, according to you, definitely we are not going to leave this meeting. You started by defining talking about the antibodies, targeting various parts of the skin and mucous membrane. You started with the pemphigus, and you did say that the pemphigus is an intraepidermal blistering disorder. According to you, since it's intraepidermal, the blisters are usually quite fragile, and we may just be lucky to find one or two blister. And you stated that there are many types of this, pemphigus. There are so many variants. We have the, foliaceous, vegetans, erythematosus, and all that. But by and large, you did say that Pemphigus vulgaris, the vulgaris is about the commonest type. You talked about
We can't hear him
Dr.
again.
Naji, you are muted. Please, can you unmute yourself, Dr. Naji?
yes, I'm on mute. Yeah, I'm unmuted now. Okay, so I said that he defined these diseases as a heterogeneous group of blistering disorders comprising of so many, but he narrowed down to just the pemphigus and pemphigoid. I hope you're audible now. Hello?
Yes, you are audible. We actually lost you for just a few minutes there. So you can continue from where you stopped. We heard it from the beginning, but just for a few minutes you were lost to us.
All right. He did state that the vulgaris has gotten so many variants. The pemphigus has gotten many variants, but vulgaris is about the commonest. He mentioned other types such as vegetans, erythematosus, and all that, with so many variants in some parts of the world, like the Fugo salvagens. He did state that sepsis is about the commonest cause of death, even though loss of fluid and other things could contribute. The pemphigus from him is usually start from 40 to about 60 years of age, although it can affect any age group. He did state that the antibodies normally target the smugglines, particularly the 1 and 3. Of course, there are other ones that are targeted in some other, many other variants, depending on whether it's the skin predominantly or the mucous membrane. And he did state that the Pemphigus vulgaris is associated with a number of clinical disease entities, including myasthenia gravis, insomnia, hidradenitis suppurativa. He mentions that the clinical features includes blisters that could be intact, but you hardly will get intact blister, but you may be lucky to just pick one. And that it could just affect, it usually starts with the mucous membrane before the skin. And the blisters are usually very flat, very flaccid. Usually, most time you see crust, you see erosions. There are many variants of this, as I've stated, but it could be localized, as evidenced by the picture he showed us of a case that is just localized on the scalp. The diagnosis is usually into a report, clinical, lab, and the lab features include what we can do in most centers. That's the microscopy H&E, and then what most centers in the country cannot do. Either you try to get the antibodies or the antigens. Antibodies using indirect immunofluorescence studies where you take the blood, but direct immunofluorescence using the patient's own skin. But then it must be in appropriate medium, the Michel's medium. The histology, from what he said, is usually suprabasal cleft, tombstone appearance of the basal keratinocyte, and then inflammatory infiltrates. Direct immunofluorescence, usually you see the immunoglobulin G. The basket woven appearance is the hallmark of the diagnosis. So in summary of this particular one, clinical features, the histology, and then immunofluorescence, direct immunofluorescence and the indirect, or ELISA, where you get the specific immunoglobulin, usually immunoglobulin G. The treatment, he talked about the aim of treatment is to induce remission, also to maintain remission. And also part of the aim, from what he has said, is also to limit the side effect of the drug, as evidenced by some supportive measures that you have to do when you're treating. He mentions that pause dosing of prednisolone could be done, of using methylprednisolone, which reduces the side effect of prednisolone. He did mention that cyclophosphamide given once monthly with prednisolone is also appropriate. He did mention several other steroid sparing agents, such as azathioprine, usually at the dose of 3 milligram per kilogram body weight. Usually, that azathioprine, he emphasized that azathioprine as a single treatment modality is not very good, because this drug onset of action, it takes about a month before the drug will start working. So it's good to have started the patient on steroid or other immunosuppressive agent. Rituximab, from what he mentioned, is with systemic corticosteroid. If assuming everything is all right, this is the gold standard, together with plasmapheresis, where you have everything, all the facilities. This is the gold standard. But I think in our own environment, from what he stated, steroid plus cyclophosphamide, and when available, plasmapheresis will just suffice. Long-term steroid, from what he said, is associated with a lot of side effects. But vitamin D analogs, Cassi D, as evidenced by what was prescribed to the patient presented, will limit osteoporosis associated with this medication. It's also good to protect the gastric mucosa by giving omeprazole. Then pemphigoid, he defined this as subepidermal blistering disorder. He mentioned that it is just one of the numerous subepidermal blistering disorders. Other ones that he mentioned include the paraneoplastic pemphigoid, includes the dermatitis herpetiformis, porphyria cutaneata, etc. It is the most common autoimmune blistering disorder, and even commoner than pemphigus. And that is not as life-threatening as pemphigus. Usually affecting people greater than 60 years of age. He mentioned about the etiology, the affectation of hemidesmosome and the ferrous proteins that are affected. He mentioned that clinically it presents with intact blisters, usually very intact blisters. And the treatment is similar to what we have in pemphigus, except few differences, including the fact that this case, you need lower doses of steroids as compared to the pemphigus. And he also mentions that the diagnosis is almost the same, except that the findings are a little different. He mentioned biopsy taken from pelyginal skin, and when you want to do immunofluorescence studies, but from the lesion itself, when you want to do your H&E in histology. He mentioned the combination of various drugs, including use of tetracycline, nicotinamide, but emphasis here is to induce and also maintain remission, and also to make sure that you have less side effects from the associated, from the drugs you're using to treat the patient. Thank you very much. Well, this is about the summary. We'll be going back to the house to entertain questions. Hello, can we have questions? Hello? Yes. Can we have questions from the
There's a
house?
question.
There's a question.
Hello? There's a question somebody wrote.
Hello.
Hello?
Hello, Prof.
Can you hear me?
Yes,
Hello?
I can hear you, sir.
Yeah, somebody wrote a question.
Hello, I can hear you, sir.
Yeah, somebody asked a question asking for place of topical steroid in Pemphigus vulgaris and Bullous Pemphigoid. If you look at the almost third to the last slide, where I listed the treatment, I specifically mentioned topical corticosteroid, especially when you have remission, especially when lesions have gone down, you can apply those medications. So you can apply topical steroid, not initially, but when the patient has gone on remission, or at least most of the lesions have gone down, you can use topical steroid as an add-on, and they will help a lot. Any other question? Somebody was asking, how do we distinguish this condition from Stevens-Johnson syndrome, extensive? Is it? An extensive psoriasis. I think it's not something that is a bone of contention here, because I expect this question from those who are not in dermatology, really, because they are the people that will have these questions, not dermatologists.
Okay, there's another question.
No, I'll answer this question first. So what I want you to do is like, if you're talking about Pemphigus vulgaris, lesions you see in the mouth tends to be erosions, not a crusted lesions on the outer part of your mucosa, as you see in Stevens-Johnson syndrome. And it affects the mucosa of the eyes and the genitalia, which you don't see in Pemphigus vulgaris. If a mucosa is affected, most of the mucosa affected are usually within the mouth, vocal mucosa, and what you do, you hardly see intact blister. What you just see is an erosion, a painful erosion, not a crusted erosion that you see on the lips or in the eye or around the eye. If you look at the slide we showed, the first slide I showed of somebody with Pemphigus, clearly I tried to show the face to show you that the eyes are very clear, which you don't see in in Stevens-Johnson syndrome. Again, constitutional symptoms like fever, malaise, and all other things are absent in patients with Pemphigus, which is a common finding with patients with Stevens-Johnson syndrome. So it's a clear-cut something. Yeah, again, drug history is not a major feature, even though some drugs can cause Pemphigus or Pemphigoid, but they are less important as it is for Stevens-Johnson syndrome. Again, there's a clear difference between severe psoriasis, which is more of a plaque. You just see scaly, dried scaly plaques, thick plaques, which you don't see in Pemphigus. So really is something that is straightforward.
Okay,
Yes,
thank you, Prof. You still have another question.
What does it say?
Question from Dr. Akalawole Michael. Such split phenomenon, the associated skin failure and deep vein thrombosis because of the protein shift and fluid shift affecting the Veco's triad. Oh, well, I think this is just more like a comment, associated skin failure, and which is currently being
what you're
talked
talking about is a very twisted thing, because you're talking about salt split phenomenon. Yeah, I think you don't know what you're talking about really, because what I'm saying, you don't do some salt split unless you have doubt on what type of subepidermal blister you have, and that's where you go to do salt split. For example, if the presentation you are thinking whether it is whether it is acquired epidermolysis bullosa or it is Bullous SLE, you know, or even Bullous, what do you call it? Pemphigus gestationis. Now you do subsplit to see where those, and that subsplit is still immunofluorescence. So you want to, it's a direct immunofluorescence where you want to see where do you have the what do you call it, antibody attaching. Is it on the roof or on the floor? In pemphigoid, even by knowing the pathogenesis, you know that you're talking about BP antigen 1, which is cytoplasmic. So you expect the stem to be on the roof, while in all the other ones, they tend to be on the floor. You get what I'm saying? Deep vein thrombosis will only occur if in fact, most patients with pemphigus are not bedridden. What I'm trying to say, they move around. It's not similar to what you see in patients who have, say, Stevens-Johnson syndrome. So the incidence of deep vein thrombosis is almost rare in patients with this particular condition because they move around. The condition is not painful. You get what I'm saying? In paraneoplastic pemphigus, here you have a background history of, you know, these lymphoproliferative disorders before you have that. And then if you do immunofluorescence, you see the staining intracellular as well as in the basal layer because the antigens that are affected are multiple. They are not only your desmoglein, but you have Leakins family also in the hemidermal component. They are also affected. So you may see staining both in the dermal-epidermal junction as well as the desmosomal components are also stained. So you see intracellular staining. So really, you have to, I don't know what your statement is, but I hope I have explained this to you. Any other question?
Any other question from the house? Okay, it's been nice, talking to, listening to Professor Yusuf M. Shehu on immunobullous disorder with emphasis on pemphigoids, Bullous pemphigus and pemphigoid. And also his resident, particularly Dr. S.T. Awal, who is a dermatology resident, all are of the Aminu Kano University Teaching Hospital. We also thank Nigerian Association of Dermatology for giving us this platform, to listen and learn. Is to learn. A word of thanks from NAD.
Thank you, Dr. Naji, for being a wonderful moderator. And thank you, Professor Shehu and Dr. Awal. We want to hear from our president, Dr. Tahir Mohammed. Please, sir, say a few closing words for us. Thank you.
Good evening, everybody. Our invited lecturer, the moderator, and everybody. Once again, we thank the webinar group for hosting another successful one. And hopefully we continue doing that every month. So please, a good round of applause to the webinar group led by Madam Ibekwe. We are also very grateful to Professor Shehu for the insightful lecture at the very short notice. Well, I want to notice that our attendance has dropped from last month to this month. So please get other people to come on. And I also noticed that people were not happy with the timing. So I think it couldn't be changed because the speaker was already informed, but subsequently, I think we'll go back to the Sunday afternoon timing, which seems to be better for most people. Am I correct? Hello?
Hello, sir.
Yes, sir. Am I correct that the Sunday timing will be better for us?
Well, it's Sunday.
Or maybe we'll shift down to the... Yes, sir.
for a poll. I think we need a poll.
That's on the next chat.
Yeah, we'll put up the poll in the NAD page, NAD WhatsApp page, so that we'll decide whether to stick to the Saturday or Sunday afternoons. Thank you very much, everybody.
Thank you, sir.
Thank you, Mr. President. Thank you, everyone. And please do have a great weekend. Bye.
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 Bye.